The following podcast is part of a certified educational activity titled 5 Steps for Integrating BCMA Bispecific Innovations, From Clinical Data to Clinical Practice in RRMM. Access the entire activity and complete the post-test at peerview.com/CAN860. Downloadable slides and practice aids are also available.
Hi, I'm Mohamed Moti from the Saint-Antoine Hospital and Sorbonne University in Paris in France, and it is my great pleasure to welcome you all to this educational program entitled 5 Steps for Integrating BCMA Bispecific Innovations. I'm pleased to welcome today my colleague and friend, Dr. Caitlin Costello from the University of California at San Diego. Today, we will focus on the European and US practice as it relates to a rapidly developing area of care in multiple myeloma and how to integrate BCMA bispecific antibodies into the management of patients with relapsed refractory disease. During this program, we will periodically share several resources summarizing dosing, safety, efficacy data, of course, but also some other practical aspects related to the management of these patients, especially when it comes to the currently approved bispecific agents. So please don't hesitate to download these point of care tools before we get started. Let's begin. I think most of you are familiar with the bispecific antibodies and their mechanism of action. This is a form of highly effective immune therapy, not only in multiple myeloma, but in different hematological diseases. And we're fortunate having 2 agents being today approved both in the US and Europe, namely teclistamab and elranatamab. Teclistamab binds to the T cells through the CD3 antigen and to the B cell maturation antigen on plasma cells. This is the tumor target antigen. Elranatamab has a similar structure, but it is a humanized bispecific, also targeting both BCMA and CD3. And once the tumor cell and the T lymphocyte are in contact, this will lead to a cytotoxic reaction, which ultimately will lead to the efficacy of these agents. When it comes to the regulatory status of these 2 agents, we can see a few subtle differences between the United States of America and Europe, where, for instance, in the US, they are approved in relapsed refractory multiple myeloma after at least 4 lines of prior therapy, including an IMiD, a proteasome inhibitor, and an anti-CD38 antibody, whereas in Europe, they are approved in relapsed refractory multiple myeloma after at least 3 lines of prior therapy, including an IMiD, a proteasome inhibitor, and an anti-CD38 antibody. And in addition, they have demonstrated disease progression on the last therapy, obviously the patient. The other important piece of information is that other BCMA targeting bispecific antibodies are currently under development with a sort of a priority review. Namely, this is about linvoseltamab. But also I'd like to highlight that other tumor antigens are being tested, and this is, for instance, talquetamab, which is a bispecific antibody directed against GPRC5D and CD3. Looking into the practice, I would say the real-life practice in Europe when it comes to standard of care in those patients who are in late relapse. We can see, as expected, actually, before the advent of these new immune therapies, that retreatment with the same drugs, with the same recycling drugs, I would say, is quite common. And obviously, this is quite easy to understand because physicians are trying to optimize the available options. However, we also know that once patients have received and were exposed to these three classes of major drugs in multiple myeloma, the proteasome inhibitors, the IMiDs, and at least an anti-CD38 monoclonal antibody, actually, these patients will become hard to treat, I would say, uh, and obviously the disease will worsen when it comes to the disease burden, but also we will see an impairment of quality of life. So clearly, these triple exposed or even triple refractory patients are a group of patients with an unmet medical need. So, with this background, our goals for today is to augment your knowledge about the latest efficacy and safety data, including the unique adverse event profiles when it comes to BCMA bispecific antibodies in relapse refractory multiple myeloma. We would like to equip you with the skills you need to develop treatment plans that integrate these bispecific antibodies targeting BCMA into relapse refractory multiple myeloma care. And last but not least, we'd like to provide you with some guidance on how to address practical aspects of care when using these BCMA targeting bispecific antibodies. And this is, for instance, about the step up dosing, management of toxicities like CRS, ICANS, infectious complications, but also transition from inpatient to outpatient care. With this, I would like to start by recapping the evidence we have today with BCMA CD3 bispecifics in relapse refractory multiple myeloma. And here I'd like to welcome my colleague, Dr. Caitlin Costello, with whom I'll share this case we have seen recently in our practice. Caitlin, thank you for joining.
Thank you, Mohammed, for that really nice summary. Let's review a case. So Charlotte is a patient who presents to us with high-risk relapse refractory multiple myeloma. She's now 77 years old. She has a performance status of 2. She's high risk because of an amplification of 1q with additional abnormalities, including a gain of chromosome 11 and a deletion of 13. Now, for her treatment history, she was initially diagnosed and received induction therapy based on the MAIA trial with a combination of daratumumab, lenalidomide, and dexamethasone. After receiving initial induction, she continued on lenalidomide maintenance alone, as she did not prefer to receive ongoing daratumumab treatment. She achieved a very good partial response, which lasted for just about 3 years. Upon the time of progression, she was transitioned over to a combination of daratumumab, pomalidomide, and dexamethasone. This triplet made good sense. She was considered to still be sensitive to daratumumab, and she achieved a partial response. This response, however, lasted for just under a year before she progressed again. For third-line therapy, she was transitioned to a proteasome inhibitor, which she had not previously seen, and received a combination of carfilzomib, cyclophosphamide, and dexamethasone. And with this, she achieved a partial response, which lasted just for about 4.5 months. Unfortunately, she comes in today with signs and symptoms of very aggressive relapse, and we are going to try and talk to her and discuss about what our next best approach is for a patient like this who clearly has triple-class refractory disease. So when we're thinking about the available bispecifics for patients with triple class refractory disease, we, as Dr. Modi mentioned, we have two classes or two targets that we can work with our bispecifics, whether we're targeting BCMA or we're targeting GPRC5D. Well, let's talk about first teclistamab. Now, teclistamab is that BCMA bispecific, and results from the Majestic-1 trial led to the approval of teclistamab. We've had some initial data come out, some follow-up data come out that really showed us that where the prior bar had been laid down to say that the FDA, for example, in the US was approving drugs that had overall response rates of about 20 to 30%, you're going to see this ongoing theme with the bispecific antibodies are getting approved with overall response rates that we've not previously seen in these very relapse refractory patients that are pushing in the 60% range. So somewhere between 60 to 70% is about the common overall response rates we'll see with all these bispecifics. So like with teclistamab with the Majestic-1 trial, some of the take-home data that we can see from this is that after close to 2 years of follow-up for these patients, the overall response rates was exactly that, 63%. Now, these are for patients who had had no prior BCMA therapy. The responses deepened over time, where the overall median progression-free survival was just under a year. The median overall survival in these patients with really had no other treatment options was starting to get close to 2 years. Now, that's teclistamab. The second BCMA targeting bispecific antibody was elranatamab. As mentioned, this was originally studied in the magnetism trials, where now we have follow-up in the magnetism 3 trials showing that it was highly effective with patients with relapsed refractory disease. Now, finally, we're starting to get some information that not only is it effective for patients who are BCMA naive, but we're also maybe going to start seeing some of these patients, however, that have had some BCMA exposure. Now, these patients, again, just like we saw with teclistamab, with elranatamab, had overall response rates in about 2/3 of those patients, just over 60%, and they were deep responses. These patients had MRD negativity rates in 90+% of patients who were evaluable. When we're looking at longer term follow up, we can see for the magnetism MM3 trials that we can see that not only does it work, it's effective, but it's durable. We're starting to see from ASH 2023 in San Diego that the overall duration of responses and the median PFS is longer than we've previously seen, where we're seeing median PFS of coming up on just under 18 months, with overall survival data still not mature. So, as Dr. Modi mentioned, there are three bispecifics that are currently approved, both in the US and the EU, with several that are still in the pipeline, with again seeing some of those overall response rates in the 60+% range, although there are subtle differences between them in terms of how they are administered and dosing schedules. Lots to look forward to. Shall we move forward to step 3? We're going to look at other factors informing use of bispecific antibodies. Dr. Modi, I'll turn this case over to you.
Yeah, no, thank you, Caitlin. And well, let's continue with the case of my patient. And maybe I would like to discuss with you, Caitlin, about the different factors that we would consider when using bispecifics, and maybe the issue of the kidney function, uh, kidney failure, patient under dialysis, the value of these treatment in extramedullary disease, and you alluded to the prior exposure to BCMA targeted therapy. So, and still, the patient are still responding to a BCMA bispecific. In our practice, for instance, kidney failure or even dialysis may not be a contraindication, and actually we can use the bispecifics. Extramedullary disease is usually hard to treat, irrespective of the treatment. So results are usually not as good like in patient without extramedullary disease, but still we would offer those patients with extramedullary disease. And last but not least, indeed, especially our practice is to use CAR T cells, for instance, if it is possible, BCMA targeting CAR T cells. And even after failure of CAR T cells, these bispecific, whether teclistamab or elranatamab, they continue to work well. Do you share the same experience?
Yes, so many of what you said is true. And this is what real world evidence is all about, right? We have the approvals from our respective regulatory agencies that tell us, when to use it in terms of prior lines of therapy. And then there's guidance in terms of dosing for lots of drugs. But when it comes down to it, we really end up trying to figure this out on our own to some degree, where, like you said, renal failure, for example, is not something that's going to be a barrier for these patients. These are not renally dosed drugs, for example. So yes, we offer it to patients who did not meet clinical trial criteria, whether that's because of renal function or cytopenias, for example. And well, hope we can get the same similar outcomes as the trial patients do. EMD is such a tough thing. Really, I think it is a high such a good example of highly refractory disease that sometimes even our best options can't overcome. But see, maybe these bispecifics or CAR T or immunotherapy are some of the best opportunities we have to overcome that highly refractory disease as we have it now.
Absolutely. I do agree with you. And currently, in our practice, any patient with relapse refractory myeloma progressing after three and more lines of therapy and unable to access CAR T cells, or at high risk of manufacturing failure, or as we've seen in this case with an aggressive relapse, definitely these are a good candidate for bispecific. And of course, as mentioned, patient failing prior BCMA targeted therapy, especially CAR T cells. And we know from the published data and the trials you alluded to earlier, Caitlin, that when we look to the issue of response when it comes to high disease burden and extramedullary disease, definitely we do have lower responses to bispecifics. And this is also true when patients had prior exposure actually to a BCMA targeted therapy. And we can see that they continue to respond in the range of 40-45% plus when they were exposed to antibody drug conjugates, for instance. But after CAR T cell, it is quite attractive because we do have responses in the range of 50% plus, which I believe is very interesting and can raise the issue on what do we know about the mechanism of resistance actually to these immune therapies. So really a big question. There have been attempts to try to understand and correlate responses, but also resistance with soluble BCMA as a possible biomarker. But I believe at this stage, this remains controversial and in all cases is not used in routine practice. But definitely, we need more research in this arena. So, with this, Caitlin, maybe let's dig a little bit deeper into how to do it, how I treat, and about the dosing and administration modalities. So, assuming, and that was exactly what happened, by the way, you decide to treat Charlotte with a ranatamab. In your practice, what kind of information do you communicate to this patient? Because obviously, these are like complex and sophisticated treatment, not easy to understand. And instead of going into the internet, maybe we should provide patient with the right information. So how do you handle patient counseling in this case, and then maybe your approach to step up dosing and whether you hospitalize them or not?
These are such complex issues. You're so right, let alone getting to the decision that we are going to use a bispecific. Now what? So it takes a great infrastructure on the hospital side, let alone great education for the patient and the caregiver team, because this is something that has kind of a more rigorous role or rigorous, intense therapy at the beginning, where then eventually becomes a little bit more challenging. Now, a lot of our patients, at least who are younger, have undergone transplant, for example, are familiar with some of the more intense therapies we have to offer. But because we know that bispecifics may have opportunities for patients who are maybe transplant ineligible, as an example, we need to kind of expand some of our treatment and prepare patients for what they're about to undergo. Now, we've known a little bit about these bispecifics and the initial what are called step-up dosing periods. Now, this is a part that we undergo with partnering with our pharmacy colleagues, with our nursing staff, with our hospital staff, so that everyone is trained. And we also allow the patients then to undergo teaching, really education, so that they know what to expect throughout this whole process. And that includes how the drugs work, what to expect from side effects, what the most common side effects are in the early interim period, and what maybe some longer term side effects may be. So if you break them down into kind of more acute short-term effects and longer-term effects, it sometimes can be more easy for the patients to understand. But there's different ways that the EU and the US, obviously many academic or community centers in the US may go about this, because there are a lot of people that are just trying to figure out how to do this. So step-up dosing is that more intense period that, at least for the get-go, for many patients will be, which will happen in the hospital, where these patients get small doses followed by medium doses, followed by larger doses, as a way we can help mitigate against some of those side effects. So we prepare the patients by educating them about what the hospitalization period will look like, their caregiver responsibilities for before, during, and after the hospital time period, and then talk a lot about cytokine release syndrome and neurotoxicities such as ICANS as examples, so that everyone's prepared for what may happen. Then we can kind of go into the longer term toxicity, including infections, which you and I will touch on in a bit. But when we're thinking about some of that education, a lot of it then is determined to some degree about dosing. When we're thinking about how we'll teach these patients to say, okay, dosing in the beginning will be much more frequent at smaller doses, where later on we'll transition to less frequent dosing. And each drug has slight differences in terms of how the dosing is recommended to undergo, whether it's one dose every 48 or 72 hours, or 3 doses or 4 doses in that step-up dosing. And then we can transition to less frequent, whether weekly or biweekly dosing schedules. So much, I think, that the infrastructure of the hospital is required to be able to prepare our patients for, but much that we need to prepare our patients and their caregiver team to know what to expect as well.
No, I think these are really good news for the patient, because obviously patients prefer to be off treatment, but when it comes to relapse refractory advanced myeloma, well, you need to do what is needed. But what is very interesting, and that was actually built up as part of the Magnetism 3 trial, actually, that in those responding patient after 6 cycles, actually, we could move into twice monthly, which is less frequent. And actually, interestingly, even when you increase the length of the cycle, actually the responses are sustained. And this is good news, because it has some benefit in quality of life, of course. But we can see also a trend, a clear trend towards less infections. And I think you have alluded to some of these side effects, Caitlin.
We can think a little bit about some of these subtle differences. You've mentioned how we can start off for elranatamab, for example, at once per week, and we can continue on weekly and then extend the frequency to maybe every 2 weeks, maybe potentially even longer. We'll figure that part out. Teclistamab is similar, where they start off patients getting into once a week and extend it out. Recently in the US now, there's an approval that after 6 months, like elranatamab, we can transition to every two weeks. So I think there's lots of little differences that may distinguish and may be important for discussion with your patient when you're looking at safety, but convenience, what kind of side effects to expect, whether it's inpatient or outpatient. These are all different considerations to be taken into the decision of which bispecific is right for your patient, who, let's say, who's in front of you. Maybe we next move on to step 5. This is to specifically looking at the prevention, the planning, and the practicalities of safety management. Starting to discuss a little bit about some of those side effects that we've just mentioned here. So, we've made the decision with our patient Charlotte that we're going to pursue a bispecific antibody. And after discussing the pros and cons and risks and benefits of all the available bispecifics, we choose elranatamab. Now, is there anything about elranatamab, teclistamab, or the different antigens that we're targeting that we need to approach differently from a safety perspective?
Well, obviously, at this stage, it's very difficult to compare across trials. So we need to be careful about these like indirect comparisons. Obviously, this patient received a ranatamab, which has a median PFS in this population of almost like 18 months, 1 year and a half, which is quite amazing, I would say, because if you look to the real life evidence and what to expect from the registries in this kind of patient, the data, the most recent data, for instance, from the locomotion study, are suggesting roughly around 3 to 4 months of PFS. So you are giving these patients 4 times more PFS with a drug like irinotecan. When it comes to infectious complications, actually, it has to do with two parameters, in my opinion. First of all, the patient. Myeloma patients are highly immunosuppressed with all the prior treatments because of the disease itself, the use of dexamethasone. So you have the best, I would say, environment, let's put it into between brackets, to develop opportunistic infection. And you're adding to this a mechanism of action which would lead to T cell exhaustion. And of course, I don't want to spend a lot of time highlighting the role of T cells in immune defenses. But also, we're targeting BCMA, and BCMA is crucial in the plasma cells to the secretion of immunoglobulins. So you have all the ingredients to actually develop, I would say, opportunistic infections. So that is the black side of the story. The good news is that we are capable through prevention, prophylaxis, systematic screening, but also immunoglobulin supplementation to avoid and prevent all of these infections. So getting the best of the bispecific without the side effects. And maybe you would like to comment on some of the data we have from the literature, Caitlin, related to infections, but also the other side effects that we discussed, like CRS and ICANS, which I believe are not a big matter of concern, especially ICANS.
I agree. Let's start there. I think the CRS and ICANS that we've seen with bispecifics are not what we've seen with CAR Ts, for example, and certainly not what we've seen with other antigen targeting bispecifics or CAR Ts outside of the myeloma world. So I think that these are a much better, let's call it tolerable class of drugs maybe than CAR T may be. That said, CRS is real, ICANS is real. We have to have plans for what happens when it develops and how to intervene on these. And I would argue that the CRS and ICANS incidents across all bispecifics that we currently have available and approved are pretty consistent. So we've talked on infections, we've talked on CRS. Let's just broadly say we've said if the incidence is similar across all different bispecifics, the CRS is most common in those first couple of doses. We know that can kind of guide us a little bit of where and how we can treat these patients when the risk is the highest and how to intervene or when to expect to intervene. But once we know that patients get to their third step up dose into their treatment doses, the risk of CRS and certainly for ICANS is considerably lower, where if the patients are not already in the outpatient setting, they can transition to it at that point.
Well, this is fantastic because obviously, I think the fear about CRS and ICANS, they are is not really a matter of concern, and I think thanks to the step up dosing, we can really control. When it comes to infections, you alluded to it. There are some clear recommendations, I would say, very easy to implement. Prophylaxis with cotrimoxazole, very easy to do, very effective. Antiviral prophylaxis and against HSV, VZV, like valacyclovir. And last but not least, immunoglobulin supplementation. I think these are crucial measures, and I strongly recommend, and I believe the practice is quite similar across the Atlantic, to use these easy to implement measures, but highly effective. And we've seen a clear learning curve and a dramatic improvement when it comes to these opportunistic infections. So we've reached the end of this lovely discussion, Caitlin, and maybe a couple of take-home messages to our colleagues. I hope everybody's convinced that bispecific antibodies as monotherapy, and the two that are approved today, teclistamab and elranatamab, are highly effective in patients with relapse refractory multiple myeloma, including those patients with prior exposure to BCMA-directed therapy, whether an antibody drug conjugate or even a CAR T cells. And interestingly, the responses are very early, as soon as 1 month after starting the treatment at the median. They are deep and they are durable in time. And we've seen that we can adjust the schedule and things can can help to accommodate all this to improve the quality of life of patient. The overall management strategy we've seen can help to mitigate CRS and ICANS. The events are mostly low grade and infrequent, and I think Caitlin, you have emphasized and explained this very nicely.
Those are great take-home points. I would only add to them just how we finished up our recent discussion on the importance of having a high level of suspicion for infections for these patients who are so highly immunocompromised, and monitoring and prophylaxing against and being prepared to intervene with treatment to help mitigate the risk of those infections. I think the combination of the effectiveness, the safety of these drugs, and the way that we can support and provide treatments that have been unprecedented for these triple class refractory patients has really allowed for bispecifics to really take the stage here for these patients and provide such remarkable outcomes that we've never seen before.
Thank you, Caitlin. I really enjoyed this discussion and I learned a lot from your experience, and will continue the work towards improving patient outcome.
Thank you, Mohammed. It's been a delight.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/CAN860. This activity is supported by an educational grant from Pfizer.